Today we're going to talk about anti-racism and mental health care. Racial minorities in the U.S. experience higher rates of mortality, greater severity and progression of disease, and higher levels of comorbidity and impairment than do their white counterparts. Individual discrimination functions as a psychological stressor that triggers physiologic, psychological, and behavioral responses, ultimately leading to downstream mental and physical consequences. Clinical care interactions, which could treat or prevent some of the negative health outcomes, are also vulnerable to racial bias. Minorities experience poorer quality of care, decreased access to care, and fewer preventive services. Pain, in particular, is systematically undertreated among Black Americans. We, as social workers and mental health professionals, have a unique responsibility to develop and implement anti-discriminatory practices. Admit to being racist to become anti-racist. Clinicians are more likely to do harm when they deny their racial biases. Racial and ethnic inequities are well documented in the U.S., but racism is rarely cited or targeted as the root cause of these inequities. Racism's power derives from the denial and obfuscation of its existence. Confessing to the racism that each person possesses is therefore a first step to becoming anti-racist. Because racism begins not with the individual, but with policies of political and economic power, Kendi argues that the word racist should be treated as a plain descriptive term for policies and ideas that create or justify racial inequalities, not as a personal attack. People are racist when endorsing or supporting racist ideas and policies, and conversely, they are anti-racist when endorsing ideas and policies that promote racial equity. Racist as a pejorative accusation that singles out individuals only ensnares people in racism's trap and freezes them in inaction. Racism pervades multiple systems in the form of housing segregation, educational achievement gaps, and health disparities. Healthcare workers possess power and authority in the clinical encounter, and their patients are vulnerable and dependent on them. For this reason, they are uniquely charged with the responsibility of deliberately acknowledging and owning bias to avoid doing harm. An anti-racist approach proposes that every clinical action is considered either racist or anti-racist, perpetuating racism in clinical care or championing against it. Thus, anti-racism becomes the framework for all interactions, and identifying and acknowledging racism becomes an opportunity to challenge it with an anti-racist clinical intervention. The second step is to slow down, pause to heighten racial consciousness, and prepare for challenging racism. Psychologist Daniel Kahneman's work describing how people think both fast and slow is a helpful lens for helping clinicians focus and translate knowledge of racism at the structural level to direct anti-racist clinical action during the client encounter. The fast, automatic brain, governing 95 to 97% of behaviors, works from unconscious associations and beliefs. The slow, more deliberate and thoughtful brain, associated with the prefrontal cortex, is activated far less frequently. Even if in slow thinking people work to avoid discrimination, it can easily creep into fast thinking. Snap judgments rely on all the associations people have derived, from fictional television shows to news reports to societal messaging. Stereotypes, both the accurate and inaccurate, exist, both those people would want to use and ones they find repulsive. Implicit or unconscious bias reflects both human nature and socialization. It lives deep within people's brains, governing almost everything they do. Developing an understanding of the power of implicit bias enables people to develop practices to minimize the impact of their unconscious tendencies to categorize, generalize, stereotype, and discriminate. Pausing long enough to heighten racial consciousness can challenge clinicians' implicit biases, thereby curbing discriminatory behavior and instead positioning them to dismantle the racism shaping the client experience. Subsequent steps provide practical tools to thoughtfully and deliberately enact an anti-racist approach. Having consciously rejected the denial of racism, reframed all clinical actions as racist or anti-racist, and cemented a foundation of slowed reflective thinking, naming and identifying racism in clinical care is the next step toward constructing an anti-racist approach. With shared language and clearer understanding of how institutions and systems are producing unjust and inequitable outcomes, anti-racist clinicians are better equipped to work for change. Kendi specifically says, the only way to undo racism is to consistently identify and describe it, and then dismantle it. Because almost all interracial encounters are prone to microaggressions, this kind of racism is particularly important to integrating an anti-racist approach to clinical care. Microaggressions specific to clinical care have been linked to poorer physical health and health service use. One paradigm, emphasizing the harm experienced by the victim rather than the act committed by the aggressor, argues that clinical microaggressions can undermine provider-client relationships, preclude relationships of trust, and therefore compromise the kind and quality of care patients deserve. Although clinicians should be directly attuned to the risk of committing racial microaggressions, they should also be conscious of potentially advancing the racism operating at the policy, ideological, and individual levels during the clinical encounter. Racism operating at one level reinforces and derives from racism operating at other levels. Clinicians are in key roles to advocate for anti-racist policies for ensuring more equitable care. By identifying the policies and ideologies shaping client experience, diagnosis, treatment, and care, anti-racist clinicians are better equipped to traverse racial bias, render just and high-quality care, and to even advocate against structural racism. So we're going to look at some types of racism and some examples, and we're going to define them. So the first type we're going to talk about is individual and internalized racism. Which is a systemic oppression and reaction to racism whereby Black, Indigenous, and people of color internalize the racism that victimizes them. It can lead to conflict among and between BIPOC people. Some examples include low self-esteem, colorism, which is discrimination based on skin color within BIPOC communities, self-hatred and self-devaluation, stereotyping BIPOC individuals, and having a sense of inferiority. Next, we'll talk about interpersonal racism, including microaggressions, which are the brief and common daily verbal, behavioral, or environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative racial slights and insults toward BIPOC people. Examples include microassaults, which are explicit racial derogations meant to hurt the intended victim through name-calling, avoidant behavior, or purposeful discriminatory actions. A micro-insult is a verbal, nonverbal, and environmental communication that subtly conveys rudeness and insensitivity that demean a person's racial heritage, like asking BIPOC people how they got their job, suggesting affirmative action, or some sort of diversity hire. Micro-invalidations are communications that subtly exclude, negate, or nullify the thoughts, feelings, or reality of BIPOC people. Like, an example would be asking someone where they're from or where they were born just because they are not white. Epistemic microaggressions are unintentional or intentional slights conveyed in speech or gesture by healthcare providers that dismiss, ignore, ridicule, or otherwise fail to give uptake to claims made by clients. Emotional microaggressions occur when physicians and other healthcare providers fail to take patients' emotional reactions and experiences into their diagnoses and illnesses seriously. And then self-identity microaggressions are when healthcare providers intentionally or unintentionally undermine or do not give uptake to the existential consequences that often accompany experiences of illness. Next, we have structural racism, which describes the totality of ways in which societies foster racial discrimination through mutually reinforcing systems of housing, education, employment, earnings, benefits, credits, healthcare, and criminal justice. Examples would include residential segregation or like education segregation. And then we have political racism, and these are any measures or procedures that produce or sustain racial inequity between racial groups. Policy is defined as a written or unwritten law, rules, procedures, processes, regulations, and guidelines that govern how people act and behave. Examples of these would be slavery and Jim Crow laws, voter suppression, police brutality, mass incarceration, the school to prison pipeline and push out of education, and redlining. And finally, we have ideological racism, and that is any idea that suggests that one racial group is superior or inferior to another group in any way. So examples of this include black criminality or violence versus white innocence, black female hypersexuality versus white female purity, black anger and violence versus white people as saviors or promoters of peace, black families as so-called tangles of pathology, the strength and resilience of black people suggesting that they somehow have superhuman abilities to tolerate hardships or to cope. And then the inferiority or ignorance of black people and superiority or intelligence of white people. So within these things, we've got coercive clinical practices like the use of seclusion, restraint, or IM medications are typically used depending on a clinical assessment of acute risk for violence or danger to others. This assessment, though, is based on clinical factors like the mental status exam, medical history, and response to medication, but notably absent from those clinical guidelines of assessment is the consideration of racism and discrimination. An anti-racist approach expands the clinical assessment by first acknowledging the high risk of abusing power, actualizing pervasive racist ideologies regarding black violence and criminality, and traumatizing people of color with their injudicious use. And then carefully considers the risk for advancing disproportionate use of punishment and violence against BIPOC people, which is well documented in law enforcement, school settings, and other environmental settings. Within this paradigm, a young black man arriving in restraints to an emergency department is likely to have been victimized by over-policing of local community and should be spared additional force when at all possible. Recalling that all actions are either racist or anti-racist clinicians instead make the experience as therapeutic and treatment-oriented as possible. For example, by reaching out to the family, explicitly acknowledging the toll of racism preceding the clinical encounter, and verbalizing a commitment to avoid racism's perpetuation in care. Diagnosis is another key conduit for discriminatory practices that demands a slowed, more reflective consideration of the insidious influence of racist ideologies and policies that are common throughout systems of care. Children of color are frequently embedded in segregated school systems with poor racial concordance between students and teachers who are predominantly white, and these students often experience standardized testing practices and curricular content that is discriminatory. They are subjected to harsh disciplinary measures, less frequently offered mental health treatment, and are more likely to be funneled into juvenile detention and prison settings. Adultification is a common racist ideology undergirding these practices. Closely entwined with criminalization, it involves seeing children of color as older, more culpable, and less in need of nurturing and support than white kids. When assessing disruptive behaviors, anti-racist clinicians go beyond a cursory examination of symptoms, weighing deliberately the socio-political context in which the behaviors emerge. Avoiding over-pathologizing or even condemning the child, they instead diagnose the racist structures causing the detriment. Similar to exercising caution with coercive clinical practices, Anti-racist clinicians can avoid disproportionately diagnosing conduct disorder and oppositional defiant disorder among children of color. Challenging the adultification these children endure, anti-racist clinicians can instead work closely with the schools and teachers to provide more supportive and treatment-oriented approaches that nurture and protect healthy development. Explicitly acknowledging the racism children experience validates and supports parents and families, renders structural racism more visible, and potentially protects against further harm. Identifying the historical origins of inequities is considered a key step to understanding why BIPOC are treated poorly and differently in the healthcare system. These historical arcs are complex, interrelated, and not openly acknowledged in healthcare training. But their identification is the foundation for codifying anti-racist clinical practices to challenge them. It's also far beyond the scope of this video to identify everything, but I will talk about some examples. American medicine was no different from other major American institutions by serving as a vehicle for legitimizing slavery, the backbone of the burgeoning U.S. economy in the 19th century. Common med school pedagogies involved determining whether or not enslaved people were sick or feigning illness and how best to provide treatment for aberrant behavior, which often consisted of disciplinary measures more accurately resembling human rights abuses and torture. Myths about physical racial differences were used to justify slavery, eventually giving rise to the scientific racism that fueled imperialism and colonization in the 19th and 20th centuries. American psychiatrists pathologized enslaved people who attempted to risk their lives by running away or who refused to work, diagnosing them with illnesses such as drapetomania and diaesthesia ethiopica. The prescribed treatment was whipping. In the 1960s, psychiatrists characterized angry, politically active black men involved in the civil rights movement as having reactive psychosis. Antipsychotic advertisements from that era sometimes featured angry, threatening cartoons of black men. Pathologizing the emotional and behavioral experiences of black people, rather than condemning the racist policies and practices being protested against, reflects a larger pattern of blaming the individual rather than condemning more macro-level racist policies and practices. It also perpetuated a narrative of racial difference by suggesting a propensity to violence and criminality among black people. These examples draw attention to, but don't fully describe, the racism embedded in American medicine and the key role that justifying slavery played in the growth of the medical profession in the 19th century. Nonetheless, they articulate key trajectories regarding the legacy of slavery in the profession and provide insight into how racial bias originated in healthcare. Anti-racist clinicians consciously articulate how American medicine and psychiatry were no different from other major American institutions, like economic, educational, legal, housing, and political, in justifying slavery and failing to condemn Jim Crow violence. This insight facilitates the slower, more reflective thinking needed to challenge the automatic fast thinking resulting in implicit bias. Key strategies for subsequently translating this knowledge into clinical practice include avoiding coercion and abusive practices, reconsidering diagnosis against this historical landscape, and making every effort to provide treatment to ensure there are no missed care opportunities. First, do no harm. Prevent the toxic exposure of racism in the clinical encounter. Because of the historical context and the known health consequences of racism, any act of racism, no matter how small, is a toxic exposure for clients and a sentinel event for the healthcare system. Inadequate or negligent care of minorities who have weathered or even died of racism across generations, particularly within a caregiving profession that violated its most basic oath, constitutes grave medical error. Accordingly, the risk of racism should always be acknowledged and accounted for by clinicians as if it were a vital sign. This consideration is particularly relevant given the significant power differentials between clinicians and clients and the risk of the former using power to enact racial subordination of the latter. Within this framework, good intentions are irrelevant. Rather, it's the impact of racism, particularly health consequences, that defines the focus. Clinicians operationalize an anti-racist approach to clinical care by reviewing the definitions of racism to see where they might be operating in the client's experience, and by checking for touchpoints and direct links to the historical arcs of racism characterizing medicine and healthcare more broadly. The overarching goal is to protect clients of color against the daily assault of racism embedded in the healthcare system, and, whenever possible, beyond. The process is deliberate and thoughtful to ensure clinicians do not default to the fast, automatic thinking behind racial implicit biases. The moments when a lead clinician argues that something has nothing to do with race or racism, or responds with silence if the role of racism is raised, are precisely the moments when an anti-racist approach to clinical care should be actualized. Incorporating anti-racist dialogue into the clinical encounter traverses the wall of silence characterizing organized medicine's stance on issues of justice and disrupts the legacy of racism in healthcare. Faculty who benefit from white supremacy bear a greater responsibility for illuminating the invisible forces of racism that shape clients' experiences. Faculty and trainees of color who face disproportionate professional and personal burdens because of racism and discrimination should not solely be tasked with improving the system. Case discussions, treatment team planning, rounds, didactics, and other treatment and educational opportunities should become the vehicle for these conversations. Racial disparities permeating the economy, housing, education, and the law raise serious concerns regarding whether certain clinical practices, although potentially justified by a current clinical presentation, do more harm than good to people of color in the long term. Although clarifying answers to these complex questions might take time, initiating dialogue among clinicians, particularly given that mental health workforce does not mirror the racial diversity of the U.S. population, is an important and immediate step in leveraging an anti-racist approach. Remaining silent or denying the presence of racism in clinical care not only stands in the face of growing demands for anti-racist healthcare, but it also perpetuates a legacy of racial injustice that demands to be challenged.